Hey, well, I think we're going to make a start. People are still slowly coming in. So thank you everyone for giving up your evening and joining tonight's online journal club for the European Journal of Hand Surgery. So a reminder of what will happen. We will discuss two papers. First of all, there will be a critical appraisal of each paper by a hand fellow, followed by expert panel discussion, and then the handling editor will share his views about the paper. And through it all, the author will be invited to give their comments. And finally, we will discuss some questions from the floor. So please do send in your questions and comments because they are a very important part of this journal club. So allow me to introduce tonight's panel. We have, first of all, Sanil Advani, our first presenter, a hand fellow from Manchester. And then Laura Bolton, our second presenter, a hand fellow from Birmingham and soon to be a consultant in Sheffield. For our expert panel tonight, we are delighted to have with us Professor Caroline Leclerc from the Institut de la Main, Paris. So Professor Leclerc is an internationally renowned upper limb nerve surgeon, past president of the French Hand Society, and a good friend of the BSSH and FESH. We are also delighted to have with us Jane McEachen from Five Scotland. Jane has published extensively in the area of carpal tunnel surgery. She runs an exemplary service in Five. Is a very active speaker in the UK. Our handling editor tonight for the two papers is Mike Rutterman from the University Medical Center Groningen in the Netherlands. And finally, we are delighted to have the authors of the two papers, Christine Johnson for the first paper from New York, and Brigitte van der Heijden, the senior author of the second paper from the Netherlands. So without any delay, let me pass the time over to Sanil, who will present our first paper. Sanil, please.
Good evening, everybody. I'm Sanil Advani. I'm currently the TIG Fellow in Manchester. It's my pleasure this evening to be presenting clinical tests for assessing the presence and quality of palmaris longus tendon, diagnostic accuracy of examination compared with ultrasound. It was published by Christine Johnson et al. In the Journal of Hand Surgery in 2020. This paper looks at the reliability of clinical examination tests for the presence of palmaris longus tendon. The assessment of clinical palmaris longus tests on patients has been described by various different techniques. They looked to determine the sensitivity, specificity, the negative and positive predictive value of various different clinical tests. As we all know, the palmaris longus tendon is frequently utilized graft in many procedures as hand surgery. Erroneous harvest, however, can lead to severe complications, increased patient morbidity, and potential injury to the median nerve. Numerous techniques have been described to assess for the presence of the tendon, but none of these tests have been compared to a reference standard, such as ultrasound. This was a blinded, prospective cohort study. The various tests they looked at are demonstrated below from left to right. Schaefer's test is performed by bringing the thumb and little finger together with the wrist inflection. Thompson's test is carried out with the wrist inflection, fingers inflection, with the thumb overlapping the flexed fingers. Mishra described two tests. The Mishra 1 test is carried out with the MCP joints in hyperextension with the wrist brought into resisted flexion. And the Mishra 2 test is carried out with the thumb in abduction against resistance. The study was carried out between November 2017 and 2018. They looked at 48 patients with 96 wrists. It was a single center study carried out at the Hospital for Special Surgery in New York. All patients were assessed by Tang and Giddens level 5 orthopedic surgeons. Bilateral wrist ultrasound was performed by MSK radiologists, and both radiologists and surgeons were blinded to the findings of each other's assessments. The inclusion criteria were any patients or aged over 18 and needing ultrasound for routine diagnostic purposes other than the assessment of the tendon. The exclusion criteria were those patients that had previous palmaris longus harvesting and refusal to have ultrasound at the institution. When the tests demonstrated a tendon. The assessor documented the test that it was most evident upon and assessed the tendon for its length. Similarly, ultrasound was utilized to determine the presence of the tendon as well as the diameter of the tendon when present from a fixed point from the wrist crease. Statistical analysis was undertaken to determine the sensitivity, specificity, and positive predictive value. And clinical examination and ultrasound findings were correlated together using the Portney and Watkins correlation coefficient thresholds. There were 96 wrists that were evaluated, and the tendon was present on 66%. The tendon was found to be absent in 19%, and all 4 clinical tests predicted this absence in 72% of cases. The palmaris longus tendon was absent on any clinical maneuver in 18%, and the examination was found to be equivocal in 17%. There were 5 wrists with a false positive test. The Thompson's test was found to be positive in all 5, with 1 wrist having a positive Schaefer's test. Overall, the Schaefer's test had the best diagnostic performance, with sensitivity and specificity of 94% and positive predictive value of 77% and negative predictive value of 99%. The Schaefer's test was found to have the highest sensitivity and specificity, and the Thompson's test was the lowest sensitivity. Mishra's 1 test had the lowest specificity. Overall, the clinical test had modest positive predictive value for assessing presence and length of the tendon, and the authors suggest that ultrasound reliably predicts palmaris longus graft dimensions accurately. In terms of our critique, the reliability of these tests may be lower with some less experienced clinicians. There can be some time constraints in the office due to carrying out these clinical examinations. We all know that there's user dependency with regards to ultrasound, and there is considerable cost and burden on resources when carrying out these tests routinely. Thank you all very much for listening, and I would like to ask the authors, have you taken into account the body habitus when assessing for the palmaris longus, and do you think that this matters?
So thanks very much, Sunil. Very interesting paper, great presentation, implications for tendon harvest and also other times as well. For example, when you want to use it as a landmark for injecting the carpal tunnel. So the question to Christine, did you get that question? Did you take into account the body habitus when you assess for the presence of palmaris longus? You're muted.
Love that table you did. I was looking at my paper. I was like, I wish we had that table in there. That was well done. So we did not specifically look at the impact of body habitus on the examination technique. In my practice, I haven't found that one of these works better on larger patients. Rather, it seems that all of these work better in slender patients and all of them fare worse in larger patients. In these larger patients, I do have a low threshold to get an ultrasound to confirm tendon presence.
Okay, your sound is sort of coming in and out, Christine. I don't know whether you can improve it. But I think we got the answer that it works better in thinner patients. That's what you're saying. And is that right?
So I haven't found one examination maneuver that works better in larger patients. Basically, in my experience, it can be less reliable in larger patients, and I therefore have a low threshold to get an ultrasound in larger patients that I can't reliably examine.
Okay, so each of these 4 tests, you find them more reliable in thinner patients. And in larger patients, you have a lower threshold for getting an ultrasound scan. Okay, right. Okay, I'm gonna go over to our expert panel first. I will go to Caroline first. What do you like about this paper? And would this change your practice?
Congratulations to the authors. I found this paper very interesting. I wasn't so very aware of all those 4 tests. I use the Schaefer's test all the time, and I thought I was going to be happy with this, but I realized that maybe I should not be as happy as I thought. I found it well done, and the statistical analysis was brilliant. I do have a question though about the length of the palmaris longus. As we all know, the fibers of the tendon kind of get lost within the muscle, and in these patients that you examined, how accurate do you think it was to find out about the actual length? Where is the end of the tendon? How do you determine, the length? That would be my question to the authors.
So we measured the tendon based on the length that we could identify from its insertion into the antebrachial fascia in the palm, as proximal as we could see to where it becomes confluent with the muscle belly. We previously did a cadaveric dissection, which confirmed with ultrasound that the average length is about 11 centimeters long. But it was challenging for our examination to determine this tendon length accurately. And we only had a correlation coefficient of 0.54 in the reliability of the exam measurements and the ultrasound measurements. So I think that our study really suggested that when tendon length is crucial, such as for reconstructive procedures, that an ultrasound is a great adjuvant to confirm the length. But I think our paper did show that with a variety of examination techniques, we can reliably assess its presence, such as for tendon transfer for radial nerve palsy, we can check that it's there. But when I need to know the length, I go to the ultrasound.
Sorry, Christine. I think there's quite a few comments that your sound keeps going in and out. I don't know whether you can plug in a earphone or something like that. It's a bit difficult to hear you. So that's a very important question, Caroline. There was a paper that the same group published in 2018 where they assessed the palmaris longus length, but they used ultrasound. So I guess we're trying to look for a clinical method that we can assess the tendon length, and maybe clinical examination is just not that reliable. Okay. So, while Christine is trying to find a way to plug in her sound, I'll go over to Jane now. So Jane, what do you think about this paper?
Thanks. This is a really neat and well-designed study. So I found a really good summary of the tests for palmaris, which I have to say I was unaware of the Mishra tests before reading the paper. And it's always reassuring that the sensitivity is quite high for these tests, but I think any false positives are worrying. So we should all perhaps be a little bit aware that you can get false positives. It's easy as a consultant to think that, you in practice you use a combination of tests. You don't maybe stick to the one. And as I was saying earlier, the Scottish equivalent is it's a modification of the Schaefer, but we ask our patients to flick a V sign, and that is something that all patients understand, so they get the movement and the trick, and that's how we assess it in Fife. I'm sure the English and Europeans don't have the same use of the V sign.
Okay. Have you got a question for Christine? We're trying to see whether her sound works.
Yeah, Christine, can you hear me?
Yes, I can hear you.
Okay. Christine, I was wondering, after reading the paper, the tests are ordered with the Schaefer first and the Mishra last. Did the senior authors perform these tests in order? And if so, do you think that there was some bias introduced by the presence of a positive Schaefer test?
I think this is a great comment. Also, is my sound better? I do have a microphone plugged in now.
Yes.
It's coming in and out. I think if you go nearer to the computer, just stay closer. I think it might be okay.
Okay. So I think that this is a great point that Jane brought up, and we did routinely perform Schaefer's test first. I do think that the order in which the tests are performed introduces bias, and this is a limitation of our study. However, the different sensitivity and specificity values obtained for each test would suggest that the examiners did look at each test independently from one another.
Okay. We have a question from the floor. Did you perform any inter or intra-observer reliability test?
We have performed intra-observer reliability tests previously, as well as within the confines of the study, and found good correlation between the two.
Between the different tests, okay. Back to Caroline. Have you got any further comments about this paper, Caroline?
Okay, maybe my next comment would be to the editor. If we're trying to understand how to conduct this kind of study. For those who are not familiar with numbers and statistics, if we are to undertake any such study, what are the numbers that you need to think about when starting any study? 20, 90, 150? How do you determine that? What helps?
We?
Yes, we can hear you.
Yeah, sorry, looked frozen. So that would be the basic question before starting your study. And as with every study, you would have to do a power analysis. That's best to do before starting the study, because post hoc power analysis mostly do not work out. And that's really also dependent on the difference you can expect. So if you want 80% power, and that's dependent on whatever you do, if you do ultrasound or a clinical test. And as with this study, it's from the special hospital in New York. They seem to have the luxury of a full capacity statistician working with them. So that was also one of the questions I asked them after the first submission. So please put in your power analysis. And fortunately, they had done that beforehand and came up with sufficient power. And they could at least show that the clinical tests that we know, as opposed to many other clinical tests, do reasonably work, at least for establishing if there is a palmaris longus or not. Whereas the length problem is difficult to assess.
Okay, I do have the same question for Christine. So you did, it's a similar question. You did conduct a power study, and that was based on 20% palmaris longus absence in the population. And then in your study, you did actually find a very close incidence of 19% absence using ultrasound, the gold standard, with 96 wrist. But initially your power study was, I think, was 88 wrist. You needed to get 88 wrist. So your numbers were just about there. Do you think you might have needed a larger number of subjects because clinical examination doesn't have the same sensitivity? It's a difficult question, Christine, but I want to know what you think.
Yeah, I think that's a good point. We did, on our clinical examination, did find a close correlation with what the previously published ultrasound prevalence of absence of palmaris longus. So of course we would have preferred to have more patients enrolled, but I don't think that the slight discrepancy between the palmaris absence in our population defined on ultrasound and that defined in population in previous literature alters our findings or the implications in a meaningful way.
Okay, right. Okay, I'm going to carry on my questions to Mike. So what do you like about this paper? Why did you accept it? There are several papers, as you know, about palmaris longus. How did this one stand out?
It was just mentioned, the authors previously published another paper that already established the methods. So in this paper, we had standardized ultrasound measurements that were kind of reliable and established before. They also had established the inter-observer reliability before, which made it more conclusive in this current paper. And the other thing is they had enough power to really make a statistical analysis of their data, which is not the case in all papers published.
Okay, so this is an example of a paper involving human volunteers. Oh, well, I mean, they're not really patients; they're kind of volunteers in that sense, isn't it? Normal patients. So many authors are keen to publish papers in this format. How can we ensure we carry out a good study involving volunteers or people with normal pathology, not normal anatomy?
Well, correct me if I'm wrong, Kastrine. If I understood it right, you did not do an actual volunteer study, but you used patients that came into the outpatient clinic and had to undergo an ultrasound anyway, and then asked them to undergo an additional ultrasound of the palmaris longus for these measurements.
That is correct. So they were patients at the clinic, but they weren't being evaluated for palmaris longus pathology per se.
So this is as they had to come there for their outpatient visit anyway, and as they had to have an ultrasound, this was like minimal extra burden for those patients. And as it is, about informed consent and voluntary patients, I think this is a smart way to include that many patients. The other way would be have a volunteer study, which has to be then from a collected group of volunteers of certain age groups, certain sexes, and whatever, depending on the entity of tissue we are looking for, which would probably even be more difficult to get that many people.
Okay, so I've got another question from the floor. Are there any clinical tests to identify palmaris longus with a distal muscle belly, which I think is quite a rare type of anatomy, anatomical variance? We can open this up to anyone at the expert panel. Christine, do you find any clinical tests that can identify this kind of palmaris longus?
And the question was for the palmaris longus variant with a more distal muscle belly?
Yeah, well, it's difficult to work out the tendon because the muscle belly is quite distal, or it extends quite distally.
Correct. I still, in my practice, I still use those same tests because they detect the presence of the tendon, but obviously you can palpate the muscle and you can feel a shorter tendon length in those cases. But same clinical test in my practice. Okay.
Jane, any comments?
It's an interesting question. It's a very, very unusual thing to find. A distal muscle belly and palmaris. You do sometimes see patients with a muscle bulge that you think is abnormal at the wrist level, and they sometimes present with it as a mass. But in fact, the most common, I've seen very few, even having 5,000 or so carpal tunnels on my database. You can count on, I think, 2 fingers the number of reverse palmaris that I've seen. Maybe okay. Caroline has got more experience of it. No.
Okay. So I got another question to ask Jane and Caroline as well. The design of this study is to kind of use patients that are coming for other reasons. I guess, as Mike say, a smart way to recruit patients. Have you guys done that? Do you guys routinely do that? Patients that come to outpatients to see you, so you make use of their waiting time to fill in forms and, just sort of make full use of the opportunity to do so. Do you guys do that? Do you think it's a good idea?
What we don't have in Fife is the resources to undertake ultrasound examinations on patients, and we would find actually funding a study like this extremely difficult. We have our only paper from Fife utilising normal volunteers is on grip strength and forearm circumference, which is was published back in 2007, and which is a very highly cited paper using normal volunteers, but it's not something that we routinely do in outpatients.
Okay, Caroline, do you do that? Do you let patients who are in the waiting room answer questionnaires about other things?
A number of years ago, I did a study on the thumb length, the length of the first metacarpal. And I asked my patients who were going to have an X-ray of the hand anyway, if they agreed to have a specific X-ray of the first metacarpal. And I was shocked because a number of them said, no, I don't wish that. And just, and then they said, having X-rays may be dangerous. They didn't mind if it was for their pathology, but if I was asking for one more X-ray for just research purpose, they were a little uneasy about that. But I have found my students and colleagues and people working around me much nicer and much more willing to help for that. So that's how we ended up doing the research.
Okay, right. So I mean, really, just to conclude that this is a valid way of recruiting patients or subjects for your study, as long as the pathology that they come in with does not interfere with what you're trying to study, and is an ethical way of studying, investigating what you want, what is your topic. Okay, I think we're going to conclude this first paper. Thank you very much, Christine. Okay, we're going to move on to the second paper now, and Laura will come and present that. While she's setting up the screen, just a reminder to really send in your questions and answers through the Q&A chat, so that we can have a really good discussion.
Good evening, everyone. My name is Laura Bolton. I am the current TIG Fellow in the Birmingham Hand Unit, and today I'm going to talk you through a paper that was a systematic review and meta-analysis of surgical options for recurrent or persistent carpal tunnel syndrome. And they were looking at simple decompression versus methods that covered the median nerve. So the problem was recurrent or persistent carpal tunnel syndrome. And the solution, as I say, was to look at simple decompression versus median nerve coverage. And the outcomes that they looked at, the primary outcome was the success ratio, so the number of patients that had a good outcome versus those that did not. And the secondary outcomes were patient-reported outcome measures, complications, strength, and sensibility. The paper held a literature review showing that symptoms can persist or recur in between 3 and 20% of patients after a carpal tunnel release. Revision surgery is performed in up to 12% of patients. Persistent symptoms are due to an incomplete decompression, whereas recurrent symptoms are felt to be due to adhesions or reconstitution of the transverse carpal ligament. The hypothesis was that an auto or allograft coverage of the nerve would preserve the space and provide a gliding surface. And the objective was to determine if there was any added value in covering the nerve when performing revision surgery. They performed a systematic review according to PRISMA guidelines using PubMed, Embase, Cochrane Library and clinical trials searched up until the 3rd of January 2020. Their inclusion criteria were to include patients that had open revision surgery in adults with either recurrent or persistent symptoms. They needed to have pre- and post-operative subjective plus or minus objective outcomes. The sample size needed to be at least 10 patients and the follow-up a minimum of 1 year. They excluded patients that did not have surgical intervention, patients that had had endoscopic surgery for their primary release, those that had no clear follow-up data, studies that used different pre- and post-op outcome measures, and papers where the abstract or full text were not available. The 3 authors independently assessed all of the abstracts and looked at the full text in any cases of uncertainty. They independently extracted the data from the full texts, and any discrepancies were resolved by discussion with the senior author. They assessed each of the studies using 4 different tools for assessing study quality: the Newcastle Ottawa scale, which assesses the selection of study groups and comparing the groups and the ascertainment of the outcome of interest. The methodological index for non-randomized studies, which is a validated score for assessing non-randomized trials. Strengthening the reporting of observational studies in epidemiology, which is a 22-point checklist used for assessing observational studies, and the Downs checklist, which is a 28-point checklist for assessing the quality of clinical trials. The outcome measures that they looked at were the success ratio of the different techniques. They used the best score from each of the studies. They dichotomized the data into resolved or unresolved, unchanged or worse, successful or not successful, and any improvement or satisfaction in pain. The results, they found that there were 908 records that were identified through the searching of the database. Once they had removed duplicates, this was reduced to 616. They screened these and found that 59 full text articles were suitable to be assessed for eligibility. And out of those 59, 20 were included in the qualitative analysis and 18 were suitable for inclusion in the meta-analysis. The 2 that were not included were excluded because of 2 different reasons. One was excluded because there was an unclear description of the outcome data, and the other because it was impossible to determine the percentage of patients who had improved. So, as I said, 20 of the studies met the inclusion criteria and 18 were included in the meta-analysis. And the studies were grouped by the intervention, either being a simple open revision carpal tunnel release, an open revision with a flap, or an open revision with some form of implant. So this is just an example of one of the papers that was included, looking at the Crafter tool paper, which used a hypothenar fat pad flap, but there were other flaps that were included in some of the other studies. And then this is an example of one of the implants, the Canaletto implant. And again, this is one of the studies that was included, but there were other implants that were included as well. So the results showed that there was a moderate risk of bias in all of the studies. Different outcome tools were used across the studies, most of which were not validated. The data recruitment was not blinded. Adjustment for confounding was seldom performed. There were 6 studies that gave a clear definition of persistent or recurrent symptoms. 12 of the studies included both persistent and recurrent symptoms, and 9 of them covered recurrent symptoms only. In all, they found 294 hands had a simple open carpal tunnel release, 275 had a carpal tunnel release with a flap, 72 had a carpal tunnel release with an implant. Their pooled success rate was 0.88, with a success ratio ranging from 63 to 100%. And they found that there was no significant difference in the outcomes between these 3 groups. This table was just summarising the different studies that were included and the outcomes that they found. 15 of the studies reported post-operative complications and or reoperations, the most common being scar-related problems, and these were most frequently encountered in the carpal tunnel release with a flap. They discussed that there is a high success ratio of repeated carpal tunnel release regardless of the technique used, but their study was limited by low quality of the included studies. Most of them were retrospective case series with small numbers. There was a heterogeneity of recurrent and persistent symptoms and a heterogeneity of outcome measures. In all, they found that simple repeated carpal tunnel release appears to be preferable to the more complex flap or implant options. They found that this avoided the donor site morbidity and also avoided the insertion of any foreign material. So in summary, they found that repeat carpal tunnel release is successful regardless of the technique, and that simple repeated carpal tunnel release seems preferable. my critique of this paper, I found that they described in their introduction that recurrent and persistent carpal tunnel syndromes are thought to be due to different pathologies, but this paper assesses studies that have included both recurrent and persistent carpal tunnel syndromes and assesses them as one group. And there's a large heterogeneity between the studies that were included, with a variety of different implants used and several different flaps. So my question to the authors is, how do you think the results would be affected if only recurrent symptoms were included in your study?
Thank you very much, Laura. Excellent presentation for a very common problem, a very comprehensively performed systematic review. So Bridget, the question to you, please.
Thank you. That's a good question, of course, Laura. That's the same question we actually had, and we had hoped to answer that question, but it appeared that the literature is not good enough to answer that question. So as you show in your presentations, there were only 9 studies who discussed or studied the recurrent carpal tunnel syndromes. And of those studies, only a few had a clear definition of the recurrent carpal tunnel syndrome. So we didn't know for sure if it's really recurrent. So mostly of the time, studies didn't even call it recurrent or persistent, but only recalcitrant. And very often they did not define it. So they did not tell us what they actually mean with the symptoms. So, and that's why it is important to show the reader that we need clear definitions for this before we can say anything, actually.
Okay, so I'll go over to Jane first. What do you think about this paper? Will this change your practice?
Thanks, and well done. It looks like an awful lot of work. I think this paper, as you say, does highlight the heterogeneity of the number of studies that are coming through, and the lack of definition of what is recalcitrant and what is recurrent. In particular, Cobb's paper of 1996, which in your study has contributed the most number of hands to the study. Actually, a small percentage of the patients that he wrote about were true recurrent, and many of the patients had no relief from symptoms or less than 6 weeks worth of relief from symptoms. It's often very difficult to interpret. We are lucky in Fife that we have a system for our carpal tunnels, a pathway which involves all patients having a nerve conduction study before their primary decompression. And the actual decompression is done by 1 of 2 people. So we have a very good understanding of what happened to our patients first time round. Obviously, if you're a centre that's taking patients from all over the place, then you don't have that understanding of what's happened to the patient first time round. And I think it's interesting, as the senior author in one of the papers that you've got in this study, we have a very low number of patients having revision carpal tunnels or carpal tunnel decompression in Fife, and we haven't really come across the problem of recalcitrant, and our recurrent surgeries actually are much lower than what's normally quoted in the literature. So I think that's what comes from having a set pathway and a defined population. Do you want me to ask any more questions? Or?
Yes, please carry on. Yeah.
So those are my comments. And actually, when I was thinking about what to ask, I did notice in your discussion that the Soltani paper that you have used in 2013 reported very good results from flaps. Now that's not anything that I've ever tried or done, but you mention that the studies following that in your study did not particularly follow the advice given by Soltani, who recommended he had pretty good results. So my question is, why do you think that practice did not change after that paper?
Okay, thank you, Jane. I like to hear that you take a common pathology like the carpal tunnel syndrome so serious, because we see often that it's people think of it that it's a minor problem, but you have to take the problem very serious. And I like the way you do it in your clinic, and maybe that's the reason why you have so results. But coming back to your question, it might be that people didn't change their practice because the conclusions were based on very small, most retrospective case studies. And also the studies were of low scientific quality. So that can be a reason that people don't change their practice. And another reason is that surgeons are not very likely to change their practice. They are not very sure that it's better, because we see it with the thumb arthritis. It has been proven that only doing the trapeziectomy is as good as combining it with a tendinoplasty. And still a lot of surgeons like to do the tendinoplasty because they have good experience with it, have good results with it. So why should we change it? So
Preaching to be converted there, I think.
So we have to be convinced that it's better, and then we need good proof, and we don't have it actually. Yeah. So I think that's my idea. That
I just wondered, as well, you've been through these papers, but the hypothenar flap is such a, it's not something I've done, but I associate that with being a plastics kind of procedure to do, and wrapping the nerve and that kind of thing. So I wondered if there was a split that, between whether these papers came from plastics or orthopedics units.
Yeah, we have looked for that association, but there was not. So half of the studies was done in orthopedic centers, and they also described the hypotenar flap. And the other centers mostly were hand center clinics, and there were both plastic and orthopedic surgeons. So I can't say that hypotenar flaps were done only by the plastic surgeons, but it might be that they are more keen to do that, but I'm not sure. Maybe they go even for bigger flaps. I don't know.
Okay, thanks, Bridget. So I'd like to ask Caroline what you think. Caroline has a maybe slightly different practice from Jane, tertiary referral center. So you see all kinds of patients, perhaps patients operated by other surgeons. So I'd like to hear what you think, Caroline. Has this paper changed your practice, and what do you think about it?
I am a little bit uneasy about this paper and its conclusions. No hard feelings, of course, but it's, the old saying of mixing bananas and apples and trying to decide what's the best way to peel all of them. And bananas are not apples. And we're not sure here what those papers are talking about. First, there is the problem about recurrent and persistent carpal tunnel. But I see a number of patients who are referred for either recurrent or persistent carpal tunnel who are not carpal tunnel. So what would be really interesting is to understand how the diagnosis was made in these papers. And we didn't hear so much about EMG studies or ultrasound. And in my practice, I would never reoperate a carpal tunnel that has failed somehow before doing another EMG study. So this would be a question for the authors, from the papers they have gone through. Was EMG studies part of the diagnosis often or not often? And this would be an important point. Now, to answer the question, has it changed my practice? In my opinion, there is no universal solution for these problems. And my way of treating these is pretty much to make my surgical decision or my operative decision intraoperatively. In some cases, it's obvious when you open that there is part of the ligament remaining. Well, that's easy. Just cut the rest of the ligament and probably you'll get a good result. In other cases, you see this nerve which is stuck under the ligament and there is important adhesions. Well, in those cases, you are keen to think that if you just release the adhesions, this is going to recur and you would be very happy maybe to interpose something in between. All the same, when you open and you see a lot of scarring and you see this poor nerve that's not white and shiny anymore, but beige, sometimes even purple, and you think, wow, this nerve really needs more vascular supply. And in those last two cases, I would be very keen to use a hypothenor flap. I don't think it takes a plastic surgeon to do a hypothenor flap. It's not a very difficult procedure. I really enjoy doing it. You know, it's just like any other procedure. You need to maybe go to the lab once or twice and read the technique, but it's a satisfactory procedure. So the one thing is that when you reopen, you need to be prepared for this hypothenor flap. So you need to harvest the soft tissues in a proper way, whether or not you're going to do it, because if you don't prepare for it, then you can't do it. So that's the only thing, you know, just be prepared. Maybe you're going to have to do it. And that would be my comment to this paper.
Thanks, Caroline. So Brigitte, Caroline, I think has brought up, I think, some of the limitations of this systematic review. Any comments?
Yeah, of course, I totally agree. And maybe it's not only the limitation of the systematic review, but the limitation of the studies, of course. And that's the problem we are facing. And that's why I think it's important to tell the people and the young hand surgeons that we need more clear definition of recurrent and persistent. And I think it's important to listen to the patients about the symptoms, because patients can tell us if how it went after the first operations. And so it's not only EMG and ultrasound. I think that the story of the patients is also very important and it can help us. And considering the ultrasound and EMG, some studies did and some not. So, and sometimes they tell and sometimes they don't tell. So that's why it is also important that you write your article according to the stroke definition, because then you get a good article and the reader knows what has been done. So that's also very important. So a lot of limitations have been shown actually in this review. So, and considering the operations, I agree, you have to be prepared to do maybe a flap, but that's also important for the patient. The patient has to be told in advance that it will be possible and has to sign an informed consent for that. And that's important that you have the whole story to the patient, that it can become more complicated than it seems. And therefore it would be very nice if we could tell the patient more before the planning of the operation. And therefore we need the definition of persistent and recurrent symptoms. I think that's really important to start at the beginning. And that's actually the main message of this review.
Thank you, Brigitte. Just some questions from the floor. A very interesting question from Phil Grieve. I'm trying to understand this question, and I'll ask all three of you. Does adding a flap or implant alter the operative code and remuneration? I think what he's trying to ask is that are there some authors who did this surgery because maybe they get more money? Maybe, perhaps. I think that's the question.
Difficult to answer, of course, but yeah, you get more money, but it shouldn't be the reason, of course. But I can't answer that question for the surgeons, but yeah, it might be. But that would be not a good practice, I think.
Jane, what do you think, Jane?
I think it probably is associated with a higher fee, but I don't really know, to be honest. But I think the discussion here is highlighting the fact that there is a lot more to come on this topic. And based on my experience with our small series in our population, what is to come is likely to need multi-centre input. And perhaps a registry of revision carpal tunnels that are investigated in a standard way, prospectively, to get the information that we are needing. So maybe that's something that one of the fellows that's on the panel tonight would be up for taking on.
Okay.
Can I comment on that, because we are almost finished now, and we're starting the Delphi study, and we start, of course, with the definition, and after we have hopefully agreed on that, then we are planning to start that study, a multi-center prospective study, and I think it would be very nice to do that with more countries if it's possible. Then we have a super study.
Okay, let us know, Bridget. I think, Mike, you raised your hand. You got a comment about, is it about the money thing, is it?
Yeah, the money thing is, it might be, but it's at least not mentioned in the papers included in the review, because no author would obviously write that down. But for as to the contents, I think it's essential that we persistent compression, as in carpal tunnel, or persistent symptoms of the patient who has had his carpal tunnel years before, and just is not having complete symptoms relief, but has no compression any longer. And the group will be intraoperative median nerve lesions, which would be patients that would come to Madame Leclerc probably after a couple of previous surgeries. And so this systematic review is a starting point for a general view on recurrent or persistent carpal tunnel. It means not everybody needs a major surgery. A lot of them just have an incomplete retinaculum and can be helped with easy surgery, but it does by
We lost you there.
Major problems to do anymore.
Okay, Mike. Caroline, you wanted to comment on that?
Yeah, I think that there are some persisting symptoms which will not be alleviated with a second surgery. And this we need to be very clear about. We need to understand the difference between dysesthesia and paresthesia. If the patient has dysesthesia, it usually means that the surgery was done late, that the nerve has permanent damage, and going back will not help. So that's critical. You really need to be aware of this and not offer surgery for persisting dysesthesia. And that's one of the big bias of the whole thing.
Yeah, that's a very good point.
Yes.
There's another question from the floor. Interesting question. In your systematic review, Bridget, do you know whether the papers looked at the initial management after the primary surgery, the post-op? I think his question is the post-op management of the primary surgery is important to prevent recurrence. Did the papers mention that?
No, there was no information on that, and that's the problem. Actually, Jane was telling that only when you have operated on the patient yourself, then you have all the information. But a lot of patients were operated by in another clinic.
Yeah.
And so that's also a problem.
Okay. Did any of the authors explain what they do if their repeat surgery doesn't work?
No.
No. Okay. So there's no algorithm. So that was another question. Okay. Now I want to ask Mike some questions now about systematic reviews in general. So how many get submitted to the journal, Mike, and how has the pandemic changed this?
Well, before the pandemic, I think we got about 30 per year. And in the beginning of this lockdown, I expected them to be less, but indeed they almost doubled or even tripled. Only the quality became a little worse with those.
Okay, so people have more time to write paper. And obviously, one of the things people thought about, if I can't get data, I will just do a systematic review.
Exactly.
But can you tell us what is a good systematic review? What what are your criteria for accepting one?
Yeah, so there's basically two different reasons. So first of all, the methodology needs to be correct. So you need to look at the proper databases, more of them, not only one. You have clear exclusion, inclusion criteria, and still keep sufficient papers for sufficient cases. And then the data should be extracted independently by several authors. And the quality of the studies needs to be assessed with proper instruments, which has been done in this review with even now 4 different quality instruments for the 4 different types of studies included. And in the end, you would also end up with enough data to draw any conclusions. And this will most probably never leave us with a definite answer on the which type of surgery is it, but it will give us a starting point. So this would be for the standard patient, but every consultant will have to look at the individual patient and then decide from this starting point which is the proper method. And so the general role would be either inform on a question that is interesting for every hand surgeon, or on another view, maybe be a review on a very rare topic, maybe something congenital, rare tumors. There is not a lot of information known to everybody, but it would be helpful for differential diagnosis to know this. That would be another example.
So you welcome systematic reviews, but they have to be done properly.
Yes, and
yes.
We have a lot of questions, but not enough data to do
sure.
reasonable, robust reviews. And that's a major problem because the definitions are not good, and that does not help you with your review, obviously.
Okay, so for a good systematic review, you need to start with really with a good question, isn't it? So what do you think of the question in this systematic review? Is it a good question? Should they have combined persistent and recurrent carpal tunnel syndromes together? Should they have just stuck to one?
I think this was one of many reviews on carpal tunnel and recurrent carpal tunnel in the last years. Actually, the question was good, but the authors, after having identified their included studies, they came across the problem of the definitions. So which made it difficult to exactly draw conclusions, especially since this review was on recurrent carpal tunnels. So some of the information I would have liked to have as editor is how long did the patients have the complaints before their first surgery? Was that 1 week, 1 year, or 10 years? Which would shed more light on the persistent complaints, for example, and also electrodiagnostic studies before and after surgery. But even most of the papers on primary carpal tunnel do not provide those data. And especially those on recurrences do not, because those authors collect cases that have mostly been treated in other centers for the first surgery. So there's a lot of information missing, basically.
Okay, so Brigitte, you want to comment on that?
Oh, he said it very good. I couldn't have said it any better.
We are coming to the end, but the questions are still coming in. Wait, hold on a minute. Yeah, people are not only putting questions on the chat, they're putting it on the question and answers, and they're texting me as well. So I think a question from Jonathan Hobby, like this systematic review provides strong evidence there is no difference between simple decompression and a flap. I think that was the conclusion of your systematic review, isn't it?
Yeah, that's correct. But of course, I still agree with Caroline. You still have to look in the theater what is really the problem. But it's important to say don't just do a flap, because there is no real proof that it will help, or is it even if it's better. But if you have a lot of scar tissue with a very bad nerve, probably you need a flap. But till now we don't have proof for that. But you have to take care of it, maybe in theater, like Caroline is supposing.
Okay, so a question. I think we'll just carry on for 5 more minutes because this is so interesting. Questions to the panel. How many of you will use a steroid injection before you jump into revision surgery? Jane, Caroline, Mike?
So I I do not routinely use steroid injection. Our patients, the patients in our series all had a preoperative nerve conduction study, clinical examination findings. And although I do think there's a role for steroid injection where the diagnosis is unclear, and for symptomatic relief in certain patients, I don't routinely use it.
What do you mean by certain patients, Jane?
Well, for example, patients who are, very elderly or, not in a position that they are keen to have an operation.
Okay, Caroline, you shook your head just now. You don't inject them.
No, I don't think I would want to inject them. I prefer to understand what the problem is. I'm afraid that the injection would mask, symptoms and not treat the problem.
Okay, Mike, do you inject them, Mike?
Some of them I do, especially if it's persistent complaints. If there's a clear indication that the retinaculum hasn't been cleaved, so that they have no relief at all, then you have electrodiagnostics that say there's still severe compression, together with an ultrasound, which shows you a little stricture, then I would operate directly. But a lot of patients come and they are 4 weeks after surgery and they still have a little bit of dysesthesia and a hard scar. So those I would inject, but that's not really my clinical suspicion of recurrence. It's still a little bit of remaining symptoms and with a good chance to improvement in the next weeks. And in those cases, I would inject if the patient wants some improvement quickly.
Okay. Yeah, there's an interesting question from Natalie Binney. Again, this is sort of a general question. It's not a systematic review. How many patients in your experience who has, after their first surgery, who has persistent symptoms, will change their doctor without telling you?
According to the review, a lot, I think, because
Okay.
a lot were operated first by another surgeon in another center. So I think it happens.
Caroline, Jane, Mike,
Well,
and I think we end with this.
They don't get a chance to change their doctor in 5 days.
I'm biased because I mostly only see patients that have been operated elsewhere before and come with complaints. So, but that's depending on the system.
I don't see any referrals in from outside with this kind of problem. So that's the difference.
Caroline, you must have experience. When I visited you, there were many patients from other surgeons.
Yeah, well, yeah, Paris is a large city. It's not like 5. And there are many surgeons. I think that most of the people who come for a second opinion after this kind of problem is because they did not get a satisfactory answer from their first doctor when the problem occurred. So if the doctor says, "Oh, let's wait," and then they come back and they say, "Let's wait for longer. Let's do a steroid injection." I'm sorry, and then they're not satisfied with what they get. This is when they come to you for second opinion after failed or so-called failed carpal tunnel.
Any of you use MRI scans routinely? So you prefer the ultrasound, okay? With nerve conduction studies, sometimes it's difficult to know whether is it a recurrent carpal tunnel syndrome or whether it is persistent nerve damage, especially in very severely compressed nerves. Any comments on that?
Yeah, that's a very good question. I think it takes a great EMG study doctor to do those studies, and that's really a great help. Having a very good EMG doctor who knows the problem, who understands it, and there are several in my area. And if they say it's not a recurrent carpal tunnel, I'm not going to operate. But it's a difficult examination, and many of our colleagues, we don't get that clear an answer in many cases.
I think we need to draw this to an end. I think this systematic review really highlights the challenges of research. I think we work with the quality of the papers, we do our best. I think it's still the best tool that we have to answer questions that we still have, but we have to be very clear and very modest when we form the conclusion. But well done, Bridget, and well done to everyone. Thank all the panels and all the presenters and all the authors for joining us on this online journal club. And yes, Bridget, I remember. I will pass the time over to you to tell us more about FASH. Thank you very much.
Okay, thank you. I just want to show you. Can I share the screen?
Yes.
Yes. To show you this, you have still 3 weeks to go. If you haven't not registered yet.
Okay. You haven't shared the screen yet, Bridget.
Oh, how is that possible?
Try again.
Share. Okay, like this?
Yes.
Yes. So please come to the FASH. You can register still. You have 3 weeks to go and it will be very nice. It's on complications or management of complications or prevention, and a lot of other things will be talked about. We have debates in the evenings and we have live surgery. So it will be a very nice program, I think, and very balanced and nice for everybody. So please join us.
Thank you, Bridget, and all the best for the organization. Okay, I'd like to thank everyone for coming tonight. So I'm going to just share screen to tell you more about the next Journal Club. Please put this in your diary. Okay, so that's the next Journal Club, 28th of July. This Journal Club happens once every 2 months. I think you get a feel of what we do. We really critique the papers, and we really try to make this an educational experience as well, about publishing and not just about the topics. So thank you very much, everyone, for joining us tonight. Thank you.
Bye-bye.
Thank you.